so it is unuseful, not useful in the adult. It is only useful in the children for the follow-up or congenital anomalies. Then the CT scan. CT scan is a non-invasive imaging modality that combines the X-rays with computer processing and uh, um, X-ray with computer processing to create the detailed picture of the cross section of the body. Data combined to form the three-dimensional X-ray imaging. Normally, the arrays are present which, with the computer process, resulting in a three-dimensional image. So it is a very important. It is the imaging of choice in trauma patient. Whenever any patient came to ER with a history of trauma, the first imaging modality is the CT scan, especially non-contrast CT scan. It is also a study of choice in detecting acute blood than the MRI because the acute hemorrhage is easily detected in the on the CT. It is best for detection and characterization of the calcification and the better visualization of the bone of the skull and bony pathologies. So it is an imaging modality of choice in case of the trauma or in case of the trauma patient with an acute hematoma or a hemorrhage. Advantage easily availability is the fast, so less limited by the patient factor like the movement or like the respiratory breathing. So these are less affected because of the fast acquisition of the images. Contraindication is the radiation exposure, so should be avoided in the pregnant women. And also there are the contrast allergic reaction if the contrast is used if the post contrast CT scan is done, so should be avoided in the renal failure patient. Then the MRI. MRI is a imaging modality that uses the powerful magnets, not the radiation, the powerful magnets, radio waves, and the computer to make the detailed picture of the inside of the body. Indications are the imaging modality of choice for the patient with neurological deficit like infarction, like transient ischemic attack. It is the optical imaging for evaluation of patient with the suspected brain pathology, any congenital anomaly, any brain tumor, whatever the pathology, it is the imaging modality. To diagnose the disease like the stroke, multiple sclerosis, infection of the brain and spine is a uh, better resolution than the CT. It is used to evaluate the spinal cord and the brain injury, evaluate the disc problem. In case of the spinal cord brain injury, brain edema, contusion, or diffuse axonal injury, these are easily picked on the MRI. But it uses the magnetic field, so the main contraindication is the absolutely in a patient with a magnetic implanted devices, mean metallic devices like cardiac pacemaker, cochlear implant, metallic fragments in the eye, and the cerebral aneurysmal clip. In these patients, the MRI is a totally contraindicated. What are the advantage of MRI? Non-ionization, non-invasive, it is a painless, it is an excellent soft tissue imaging with a high contrast sensitivity than CT, MRI, or then CT, X-ray, or ultrasound. It is an excellent soft tissue contrast resolution. The axial, sagittal, coronal, and oblique images are obtained without repositioning of the patient. Patient lie in a supine position, axial images are taken, and then from there we reconstruct this sagittal, coronal, and oblique image. There is no any bony artifact, less contrast allergic reaction than the CT. So they can be used in a patient with a chronic renal failure. Then the disadvantage main is the expensive. It is available in large setup only because it needs trained staff. The if the patient is claustrophobic, so because in MRI patient have to lie down in a closed tunnel inside that, so the claustrophobic patient can avoid it. There is a long scanning time. CT can be done within a minute, needs around 15 to 10 MRI. brain. So because of the long scanning time, there is a movement, evidence of the movement are scan produced. So the axial sections are most important in cross-sectional imaging because from the axial sections we uh, reconstruct the coronal and the sagittal images. Axial mean transverse images of the body, and the coronal mean anterior-posterior division, sagittal side-by-side division. These are reconstructed from the axial. So the patient when lie down in the tunnel of either in the CT or in an MRI, so the axial images are taken from which we reconstruct the coronal and sagittal images. Then the most important topic which I want to cover that is the MRI sequence. Just brief, because MRI is not just one imaging modality or one just image sequence. There are a lot of imaging modalities sequences are taken. But for the brain, the most important sequence are the T1, T2. The T1 weighted images, which usually written as a short form is T1. T2 weighted images, sorry, this is T2, written as a T1. T2 weighted images, fluid attenuated inversion recovery. You in report, you always these short forms, not these bigger ones. Always these short forms are used. Fluid attenuated inversion recovery, DWI, ADC mapping mean diffusion weighted or apparent diffusion coefficient, susceptibility weighted image or gradient echo. Post gadolinium is a contrast which we use in the MRI. And the MRA, MRV, magnetic resonance angiography and venography. Angiography means for the visualization of the arteries and venography for the veins or the dural sinuses. The T1 weighted sequence is useful for the anatomy, for a study of the anatomy or for normal anatomy, in which the fat is bright, meaning the subcutaneous fat is white. The water or a simple fluid, whatever the normal fluid is, it is white, black. Cerebral gray matter, which is lying the cerebral cortex, is the gray. Cerebral white matter, this is the white matter. And the subcortical or deep white matter, that is the white. Acute hemorrhage, melanin, proteinous material, and the gadolinium contrast, which I told we use in the MRI for the contrast for the MRI. These are the bright. Mean normally we see the fat is bright, fluid is black, gray matter mean the cortex is the gray and the white matter is the white, mean sequence is T1. Whenever you see any MR image, your first look should go to the normal fluid in the brain, mean ventricle. We have to see the CSF. If it is a black, mean most likely T1. If it is a white, mean T2. This is the also T1 weighted image. This is the post contrast T1 weighted image. How we can differentiate post gadolinium? This is T1. We cannot see these vessels. You see, these white lines are going there and there. These are the vessels. Whenever we see these vessels, mean it is a post contrast image. You see, these vessels are there. So these are the vessels which are highlighted by the gadolinium contrast. So this is the post contrast, this is the plain T1 weighted image. Then the other sequence is the T2 weighted image. Your look should go to the CSF. It is the white. It is this sequence is useful for identify the pathology in which fat is bright but less than the T1 weighted. You see, this fat is very much bright, but this is somewhat blurred. And then the water and the simple fluid is a bright. Cerebral gray matter is gray, but white matter is dark. See, in this sequence, it is a white. In this sequence, it is a black. So we have to differentiate these four parameters. Fat is bright but less than the T1. Fluid is white. White matter is dark or a black, and the gray matter is gray. This outline, this is the gray matter, which is also gray in both. Axial T1 and T2 for the difference. This is the white matter. White matter on T1, white matter is a white, gray matter is gray, fat is bright, and the fluid is black. While on T2 weighted, the fluid is white, white matter is dark, gray matter is gray, and the subcutaneous fat is bright but less than the T1 weighted image. In this, both are the bright. Then the fluid in attenuated inversion require are a flare imaging. Flare imaging is basically the T2 weighted image in which we nullify or cancel the signal from the simple water which present in the body, like the CSF. Mean, you see this gray matter is gray and this is somewhat dark gray. This white matter is somewhat dark gray and the subcutaneous fat is bright, but CSF is black. So in flare sequence, it is just like T1, but the white matter is gray on the flare sequence. So whatever the abnormal fluid is present, either edema, either any lesion, tumor, ischemia, or lacunar infarct, they appears bright on the flare image because these are the abnormal fluid. While normal fluid appear black, like CSF in the ventricle or encephalomalacia when there is a brain atrophy or a brain necrosis. So it is replaced by the CSF. So that is also appears black on the FLAIR imaging. Then this is the very important slide which show on which sequence define the abnormality best. Like T1 is for the subacute hemorrhage, any fat containing structure like lipoma, or for the anatomical data. These best described by T1 weighted images. While the T2 weighted images for the edema, demyelination, infarction, or a chronic hemorrhage. These are best described by the T2 weighted image. Then the FLAIR images, edema, demyelination, and infarction, which are in periventricular region. Because when the infarction is periventricular region, it appears high on T2 weighted image, and the CSF is also high. So sometimes these cannot be properly identified. But in case of the FLAIR images, because CSF is suppressed, means signals from the CSF cancel, and the infarction in the periventricular region appears bright. So they are easily picked up on the FLAIR images. Then the diffusion weighted image are apparent coefficient mapping. The DWI is most sensitive sequence for the stroke image. If the patient came with a prescription of the plain MRI, we do the T1, T2, and the FLAIR imaging. But when the patient is suspected for the stroke or with history of the deficit, we do the T1, T2 FLAIR along with the DWI ADC mapping because this is the most sensitive sequence for the stroke, in which normally the physics of the MR is very difficult and it is beyond your level. But just it is show the diffusion restriction. In a way that normally the water protons have the ability to diffuse extracellular. Means from the cell, the water molecules have to diffuse extracellularly and lose signals. So, but when there is a diffusion restriction, means there is an infarction or there is any restriction, so water cannot go out from the cell and inside the cell it appear as a bright. Mean whenever high signal, any lesion which give high signal on DWI, this is the DWI, this is the ADC. Whenever any disease which give high signal on the DWI and low signal on the ADC, mean there is a diffusion restriction, and it is most commonly given by the stroke, is infarction. Especially in a hyperacute stage, within 3 hours, it gives the signals, while the other sequence may come normal. Then the gradient echo or susceptibility weighted image. It is used either, this is the gradient echo. You see these vessels are black, because it gives it identifies the calcific deposit or a blood. Mean whatever the blood, either within the vessel or in the parenchyma, it drop the signal. It appears black on the SWI or the gradient echo. Basically, this is the flare sequence. Everything is a black, black, black. So you see there is an abnormal signal, white signal in the postparietal region, right postparietal region. It is inconclusive whether it is a hemorrhage, it is an infarction, or it is something else. When we do the SWI or a gradient echo, it shows the dropout signal. Dropout means it appears black on the gradient echo or a SWI sequence. So it gives the dropout signal which confirm that it is a hemorrhage. So this is a hemorrhage which gives the dropout signal on the SWI or a gradient echo. This is the same name. Then the MRA is the specific type of the MRI that examine the arteries without visible overlying structure. Whatever the parenchyma is there, it is blurred, and we only see the vessels in which we didn't give any contrast. This is depend on the physics of the MRI, but we do not give the contrast for MRA. For the post contrast image, we give the gadolinium contrast. But for the MRA, we do not give the contrast. This is basically depend on the sequence or a frequency which gives the arteries is a bright. Then the MR venography, it is the MRI type of the MRI that examine the veins and the dural sinuses. This is the superior sagittal sinus. This is the straight sinus, and this is the inferior sagittal sinus, vein of Galen, transverse sinus, and these are the cortical vein, which we see on the MRV. But in MRV, we use the contrast. In MRA, we do not use the contrast. Okay. Now the gross anatomy of the brain. This is the gross view. This is a frontal, parietal, occipital, and the temporal lobe. This is the cerebellum and then the brainstem. This is the external view. This is the internal view. And this is the ventricular system. And this is the corpus callosum. Basically, we have to see these structures on the brain. This is the CT. This is T1 weighted MR. In the CT, we'll see the bone is a high density. You see, dense. In CT, for reporting of the CT, we use the word hyperdense, hypodense, isodense. Hyperdense means white, hyperdense means black, and then the isodense means same to gray matter or white matter. And in MR, we use the word hyperintense, hypointense, or isointense, intense. And in this, the dense. So this is the MRI. This is the CT. In the CT, we see this is the interhemispheric fissure, and this is the white matter, gray matter, frontal lobe, parietal lobe, and then there is a central circle. So in front of this, there is a frontal lobe. This is the parietal lobe. Then there is a on the lower down. This is on the high parietal lobe. Lower down, we see these are the body of the lateral ventricle. In front of the body of lateral ventricle is the genu of the corpus callosum, and then here is the rostrum of the corpus callosum. Anteriorly, the frontal, this is the parietal lobe. Then lower down again, anteriorly frontal lobe, this is the parietal lobe, this is the occipital lobe. Here it comes. When these triangular structures come, this is a trichome. We see behind that occipital lobe. Genu of corpus callosum, body rostrum of corpus callosum, and these white structures. These are the thalami. These are the frontal horns of the lateral ventricle. Just beneath the frontal horns, there is the caudate nucleus, and this is the lentiform nucleus, which contains the putamen and the globus pallidus. Below that, this is the Sylvan fissure, And when we see the Sylvan fissure, the temporal lobes come. This is the Sylvan fissure. And now the temporal lobes comes because we are going down. And this is the pineal region. This is the third ventricle. And here are the basal ganglia, lentiform nucleus, quadrate nucleus. These are the thalami. Thalami are adjacent, are on the side of the lateral ventricle. Uh, More inferior, this is the midbrain, butterfly shape midbrain. This is the midbrain, and there here is the temporal lobe. This is the temporal lobe, and these are the cistern, quadrigeminal cistern, and anteriorly is the suprasellar cistern. Again, lower down, this is the pons because for the posterior fossa CT is not good because of Peter's bone, Peter's apex, which obscure the most of the structure. In these cases, the MRI is the best. This is the cerebellum, pons, temporal lobes. Lower down, this is the medulla. This is the medulla, and then these are the cerebellar tonsils and cerebellar hemisphere. Anteriorly, here is the frontal lobe, and this is the temporal lobe. Again, this is the sagittal MRI. This is the coronal MRI. Sagittal MRI, this whole structure is the corpus callosum, and this is the lateral ventricle, body of the lateral ventricle. This is the pineal region, and this is the midbrain, pons, medulla, cerebellum. This is the fourth ventricle. And on the coronal view, this is the basically a body of the lateral ventricle. This is the body of the corpus callosum and third ventricle. This is the fourth ventricle, and these are the temporal horn vesicle, temporal lobes, and this is the parietal lobe. So we have to see the anatomy on all sequences. The normal blood supply of the brain comes from the anterior and posterior circulation. The anterior circulation from the internal carotid artery with its branches, anterior cerebral artery and the middle cerebral artery. The posterior circulation is from the vertebro-basilar artery, meaning two vertebral artery join to form the basilar artery, and then they divide into the posterior cerebral artery. Roughly, there the anterior cerebral artery supply most of the medial part of the brain, and this is the some thin strip of the lateral aspect of the brain. Laterally, most of the medial portion is supplied by the middle cerebral artery, and posteriorly, the occipital lobe and the inferior part of the temporal one by the posterior cerebral artery. Then, territory-wise, this is the anterior cerebral artery which supplies the medial aspect. This red is highlighted by the anterior cerebral artery which supply the medial aspect of the cerebral hemisphere and part of the lateral surface. And then this yellow is the middle cerebral artery which supplies most of the lateral aspect of the cerebral hemisphere. And then there is a posterior cerebral artery which supplies the posterior aspect of the occipital lobe and part of the thalami. So these are the branches which arise from the various portion of the posterior circulation, like posterior inferior cerebral artery, anterior inferior cerebral artery, and choroidal artery arise directly from the internal carotid artery, and the lenticular spreaded from the middle cerebral artery. These artery basically supplies the basal ganglia and comes from the different source, and their pathology depend on their different mechanism. This is the vascular supply from the of the basal ganglia. This is the basically quadrate nucleus, thalami, and this is the lentiform nucleus. The internal capsule run between these structures. The anterior limb is between the quadrate nucleus and the lentiform nucleus, anterior limb of the internal capsule. Posterior limb of the internal capsule run between the thalami and the lentiform nucleus. Where the anterior limb and posterior limb join, they form the genu. So the supply depend on the medial lenticulostriated arises from the anterior cerebral artery, and the lateral arises from the middle cerebral artery. They supply the basal ganglia. Like while the posterior circulation supply the thalamus, and this one anterior colloidal artery mean internal capsule, posterior limb of internal capsule is supplied by the anterior colloidal artery, which usually arises from the internal carotid artery. Now the CT in acute infarction arrest, which findings are there? The non-contrast CT of a brain remains the mainstay of imaging in the setting of acute stroke. What are the benefits? It is a fast, inexpensive, and readily available at every center. The main limitation is the limited sensitivity in acute setting, mean in hyperacute infarction and the time of the scan from the onset of the symptoms. If it is within the for 1 hour or 2 hours, the CT most of the time is not. The goal of CT in acute setting, then why we are doing the acutely? Because to exclude the intracranial hemorrhage. Because if there is an intracranial hemorrhage, we do not give the treatment of thrombolysis. And the acute intracranial hemorrhage, not MR is not very much sensitive to detect the acute intracranial hemorrhage. So the CT is to see any, if there is a no any intracranial hemorrhage, the MR patient can go for the MR if CT is not. To exclude other intracranial pathology that may mimic a stroke like the tumor. Then the stages of the acute cerebral infarction on a CT are the hyperacute, in which mean less than 12 hours of the onset of the symptoms. Normal CT in up to 60% of the cases. In these cases, the MR can detect the infarction. Here, the main role is to exclude the intracranial hemorrhage. If there is no any intracranial hemorrhage, the patient go for the thrombolysis, patient go for the MRI. Then the acute, it is again divided in early acute and late acute. Early acute means 12 to 24 hours, late acute 1 to 7 days. In early acute, the signs may be the dense middle cerebral artery sign, obscuration of the lentiform nuclear, and the insular ripping sign. Dense middle cerebral artery means there is a thrombus in the vessel, middle cerebral artery. I show all these signs on the CT. Late acute means 1 to 7 days, in which there is a low density basal ganglia, sulcus attachment, and there is an increasing mass effect because of the edema, because of infarction. Then there is a subacute phase, means 7 to 30 days. There is a bell-shaped low-density area involving the gray and white matter, and with time there is a decreasing mass effect. In subacute phase, there is a possible hemorrhagic transformation of the infarction can occur. While the chronic means more than 30 days, there is a demarcated hypodensity, which is similar to CSF, because now the tissue has got necrose and it is replaced by the fluid, CSF. So it gives the signals to CSF. And there is a negative mass effect, means the mass effect is decreased and there is the ipsilateral dilatation of the lateral ventricle because of the necrose brain parenchyma. There is the atrophy resulting in the loss of the volume with the dilatation of the ipsilateral ventricle. So there is a negative mass effect in the chronic phase and there is a dilatation of the ventricles. See this structure, dense, a tubular structure. This is the middle cerebral artery location and this is appears white, dense, because of the intravascular thrombus, which you are sometimes seen in the acute infarction. Then there is the obscuration of the lentiform nucleus. Here you see there is a quadrate nucleus. This white, somewhat white structure is the quadrate nucleus, and this is the lentiform nucleus. Here we cannot appreciate. There is the loss of delineation of the basal ganglia. We cannot see. This is also the acute sign of the infarction. Then there is an insular ribbon sign. Insula is really given name to the. This is the normal Sylvan Fisher. From here, the temporal lobe start. This is the demarcation. Lateral, uh, lobe is involved, temporal lobe is start, and here is the parietal lobe. The cortex, which is anterior to the Sylvan fissure, this cortex, it is the insular cortex. It is known as insular cortex. So, mean insular ribbon sign when there is a hypodensity and the swelling. You see the difference between two insular cortex. There is a hypodensity and swelling of the insular cortex from the left side, and it is also a sign of the infarction, especially in the middle cerebral artery. Then the late acute infarction, there is a hypodense lesion in the right frontoparietal region with a mass effect. You see there is a effacement, this ventricle and this, there is a difference in size. So there is a effacement of the uh, ipsilateral lateral ventricle. This hypodensity is the frontoparietal region, and there is a adjacent insular cortex. This is the insular cortex. Insular cortex is also involved. Basal ganglia is also involved. So this is the late acute infarction. In the early, we see the insular ribbon cortex sign, dense middle cerebral artery sign, and there is a obscuration of the lentiform nucleus. And then now the subacute infarction. In the subacute infarction, there is a chance of the hemorrhagic transformation. There is a large hypodense region involving the left frontoparietal region, periventricular region, and with a slightly midline shift. We draw a line from this middle structure to this, and then compare how much there is a displacement. There is a midline shift, and there are the scattered. You see these white structure. This whole is the black, but there are the white lines. These likely representing the hemorrhage, mean hemorrhagic transformation in the infarction. So this is the subacute infarction. This is a CT scan of a chronic infarction. You see there is a hypodense lesion in the left frontoparietal region. It is same signals are the same intensity density as the CSF in the ventricle. Both are looking almost similar. So this is the basically CSF which is replaced in the brain parenchyma in the chronic infarction. And also there is a negative mass effect which we assess like there is a dilatation of the ipsilateral lateral ventricle, and there is a somewhat atrophy. You see this parenchyma, and this is normal parenchyma. There is the atrophy of the parenchyma, and there is a dilatation of the ipsilateral lateral ventricle, which representing the negative mass effect. So this is the chronic infarct. Anterior cerebral artery infarct, when there is a infarct in the frontal lobe or in the medial aspect of the frontal lobe. So this is the because this supplies here. Anterior cerebral artery supplies here. So this is hypodense lesion in the anterior in the right left frontal lobe in the territory of the anterior cerebral artery. So likely representing anterior cerebral artery infarction. There is a hypodense lesion in the left frontoparietal region with a mass effect over the ipsilateral lateral ventricle. There is a midline shift. So there is a this is the infarction in the territory of the middle cerebral artery. You see this supply. Then there is a hypodense lesion in the left occipital region with a somewhat effacement of the ipsilateral lateral ventricle. There is no any midline shift. So this is in the territory of the posterior cerebral artery circulation. So this is the posterior cerebral artery infarction. Then the lacunar infarct. Lacunar infarct are basically very small infarct, 2 to 20 mm. See the size, 2 to 20 mm in diameter. These are result from very small terminal penetrating arteries that provide the blood supply to brain deep structure. These are the main vessels basically. Middle cerebral artery, endocortical arteries, anterior cerebral arteries. From these, the penetrating artery which supplies the structures there. These are the these produce the lacunar infarct in the basal ganglia, in the thalami, and in the brainstem. On CT, the lacunar infarct appear as a hypodense region. So this is in the basal ganglia and the thalami. Then the intracranial hemorrhage. Intracranial hemorrhage means the extravascular accumulation of the blood within the different intracranial spaces. The etiology is the most common cause of the intracranial hemorrhage is the trauma like RTA. The other causes could be the vascular malformation, hypertension, tumor-related hemorrhage, and the cerebral venous thrombosis. The tumor-related hemorrhage means any tumor which is highly vascular, in which there is an increased chance of the hemorrhage. In, so it has also appeared as a hemorrhage, intracranial hemorrhage. Cerebral venous thrombosis when occurs, it resulting in the hemorrhagic infarction in the brain parenchyma. So categorization of the intracranial hemorrhage based on the location, intraaxial and extraaxial. Intraaxial means within brain parenchyma. Whatever the hemorrhage is present within the brain parenchyma means intracerebral hemorrhage, basal ganglia hemorrhage, lobar, any frontal, parietal, occipital hemorrhage, cerebellar hemorrhage mean a hemorrhage within the brain parenchyma, either in the cerebrum, cerebellum, basal ganglia. These are the intraaxial hemorrhage. Extraaxial hemorrhage means outside the brain parenchyma, either within the dural spaces or within the ventricle. Mean these are the extradural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, and the intraventricular hemorrhage. They are the different type of the extraaxial hemorrhages. The CT scan almost always the first imaging modality used to assess the patient with suspected intracranial hemorrhage because the acute blood is markedly hyperdense compared to brain parenchyma. We have to do CT, either the patient which came with the history of the stroke or with the history of the trauma to exclude the hemorrhage. It is appear mildly hypertension. The stages of brain hemorrhage in CT are the acute, subacute, and the chronic. Acute like appear as a hypertense, subacute is a isodense, chronic is a hypotense. So the types of the intracranial hemorrhage, epidural, subdural, subarachnoid, intraparenchymal, intraventricular hemorrhages we do. The extraaxial hemorrhages, like the epidural, subdural, and subarachnoid, we have to differentiate it. The epidural hemorrhage is between the skull and dura because brain has three layers of the meninges like the duras and arachnoid and the pia. The epidural, epi mean above. So epidural means the hemorrhage between the skull and the dura. It is usually due to the tear of the middle meningeal artery, in which the patient has lucid interval followed by the intrational. Initially, the patient is well, then there is a unconscious. It appears on a CT as a biconvex. Subdural is between the dura and the arachnoid layer. It is due to the tearing of the bridging veins, in which the patient usually present with a gradually increasing headache and a confusion. On CT, it appears as a crescent shape. The subarachnoid hemorrhage is within the subarachnoid space, mean below the subarachnoid layer. It is mostly due to the ruptured aneurysm. Heavy malformation or a brain contusion can lead into the brain hemorrhage, subarachnoid hemorrhage, in which the patient usually present with acute headache with a history of severe or a worst headache of my life. Then there, in which the blood or hypertensity is seen in the sulci, fissure, ventricle, and the basal ganglia system. So this is the subarachnoid hemorrhage. This is the diagrammatic representation of the various types of the intracranial hemorrhage. This is the intraparenchymal hemorrhage within the brain parenchyma, and this is within the ventricle, so intraventricular hemorrhage. Epidural hemorrhage term is a biconvex. It is between the skull and the dura. The subdural is between the dura. It is a crescent shape between the dura and the arachnoid, while the subarachnoid is within the sulci and in the fissures. This is the coronal view and this is the axial section of same structure. Then the epidural hematoma is the collection of the blood between the inner surface of the skull and the outer layer of the dura. This is the epidural biconvex between the skull and the dura. It is usually associated with the history of trauma, and the most of the time there is an associated fracture. And because of the fracture, there is a usually a damage or a tear of the vessel, that is the middle meningeal artery. On CT, it appears as a acute hemorrhage appear as a hyperdense, and because there the this is the CT scan brain window, and this is the bone window. In bone window, we only see the bone. All other structure are obscure. And in the brain window, we see the brain parenchyma. There is a bilateral biconvex hypertense lesion in the frontal lobe with a mass effect over the ipsilateral lateral ventricle, and there is a also there is a swelling, soft tissue swelling of the scalp tissues, which is also white, hyperdense. So likely there is a soft tissue hematoma, and this is the frontal epidural hematoma bilaterally. On this, you see the importance of the bone window. There is a fracture of the right parietal bone or left parietal bone. On the brain parenchyma window, we can't see any fracture. We just see only the hemorrhages, but there is no any fracture is visualized. So for fracture, we always need the bone window. Most of the time, it does not appear on the brain parenchymal window. Then the subdural hematoma is the collection of the blood in the subdural space between the dura and arachnoid metal of the mirror. It is around the brain. It is the crescent shape, and it is due to the head trauma and bridging of the uh, 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 dural veins, bridging veins. On the CT, there is a hyperdense crescent shaped region in left front of parietal region with a slightly mass effect over the ipsilateral lateral ventricle. There is a slight midline shift. So this is the subdural hematoma. Similar lesion is also seen on the left parietal posterior frontal and parietal region. This is also another subdural hematoma. You see, there is a isodense lesion. This lesion, isodense lesion, with a mass effect over the lateral, but there is no any midline shift. It is isodense. So this is the subacute subdural hematoma. This is subacute phase, and then this is the chronic subdural hematoma because it is appears hypodense, and it is a crescent shape with effacement of with displacement of the lateral ventricle, and there is a midline shift. So chronic subdural hematoma. I mean chronic hematoma appears black. Subacute hematoma appear as isodense. Acute hematoma appear as a white or a hepatine. The difference between the epidural hematoma and subdural hematoma. The epidural hematoma, this is the radiological and the diagrammatic. It is a just like lemon shape, and this is the banana shape region. So epidural hematoma is between the skull and the dura. It is a biconvex in shape for this convex surface and this convex surface. It cannot cross the suture because it is between the skull and dura. I mean, periosteum is attached over the suture, so it cannot cross, and dura is attached to the suture, so it cannot cross the sutures. Epidural hematoma cannot cross the suture, but it can cross the dural reflection like falls and tentorium. Mean epidural hematoma can cross the midline, but cannot not cross the lymphoid suture or the coronal sutures. The common cause is the fracture associated there. Subdural hematoma is between the dura and the arachnoid. It is a crescent shape. It crosses the suture because it is between the dura and the arachnoid. Dura is attached to the suture, but here arachnoid is not attached, so it is free. But it cannot cross the dural reflection like false and tender. I mean, it does not cross the midline. It remains here. The common cause is the tearing of the cortical vein because these veins are present there. Then the subarachnoid hemorrhage is the hemorrhage between the subarachnoid space. Cause is the trauma and the aneurysm, and patient usually present with a sudden onset of the headache, which is the worst headache. These two are the different patient. Axial section, non-contrast CT scan, dead flow. There is a hyperdensity. You see this, these are black. These sulci are black, non. But there is hyperdensity within these sulci, within the entire hemisphere of the chest. Mean it represents a subarachnoid hemorrhage. In this, these are the basal cistern when where there is a hypertensity. So this is also indicating the subarachnoid hemorrhage because it is within the fissure, within the cistern, within the uh, uh, sulci. Then the intracranial, intracerebral hemorrhage, this is a hyperdensity within the brain parenchyma in the thalamus. So it is a within the left thalamus and the left internal capsule. So this is the intraparenchymal hemorrhage, and it is the typical. This is the typical location for the hypertensive hemorrhage. This is another case of the brainstem hemorrhage within the fawn. There is a hypertense region. This is another case of the cerebral hemorrhage with intraventricular extension. This is within the intraventricular trigone of the lateral ventricle. And there is also in this lateral ventricle, there is a hypertensity. So there is the intraventricular extension of the hemorrhage from the intraparenchyma. This is most of the time occur. So if you have any query, you can ask.